Okay, so moving on to our first presentation, we have Brian Schultz, who I know is just kind of hanging out today, but Jen Modello with us from Indego. They are going to let us know what it is that they do, how we can be involved, and all of the good things like that. So I'm going to turn off my screen and eat some dinner, but I'm looking forward, and welcome Jen and Brian.
Perfect. Well, thank you, Megan, and thank you for all of you for joining. Looks like you guys have a great chapter set up, so I'm excited to kind of let you all know a little bit about Indego and what it is. I'm just gonna share a couple slides with you guys, have some great videos, some photos as well. Again, just to kind of give you a brief update on the Indego. So Indego is an FDA approved exoskeleton for personal use. So I just have some great information to provide you guys, some great pictures and videos that we'll just be going over. And like Megan said, if you guys have any questions, feel free, let me know at the end of my presentation or at the end of the meeting in general. And there will also be a slide with my contact info. So feel free to reach out to me that way as well, if that's easier. So again, just a little introduction. My name's Jen. I'm a physical therapist. I work with the Indego exoskeleton, and my colleagues and I work very closely together, and Parker Hannafin is the manufacturer of the device, which is actually located in Ohio. So we all work closely and really want to bring this information to you guys or to share it with others that you guys know as well. So just to get started, so what is Indego? So Indego is a powered lower extremity orthosis. And so there's motors at the hip and the knee joints. So you'll be able to see in this video that there is a woman who has a complete spinal cord injury, and she's able to use Indego to ambulate in her community, get out and about in a standing upright posture. Indego is really designed to be used anywhere. It can be used in the home, in the community, at work, during different activities. It's really up to whatever you're interested in doing with Indego. It was really designed to go there with you. So whether that is in your home environment, in the work environment, whatever personal goals that you have, we're here to help kind of figure out if Indego can be a part of reaching those goals. A little bit about the features of Indego. First, it's very lightweight and it's modular. On my next slide, you'll be able to see, but Indego itself actually breaks down into 5 separate pieces. So you can don and doff it in most personal wheelchairs, and it can also be used to transfer in and out of the passenger side of most vehicles. Because it's modular, it's very lightweight. The whole device altogether only weighs 29 pounds. And because it breaks apart into 5 different pieces, you can fit it in a 22-inch duffel bag, bring it with you wherever you want to go, put it on when you get there, and stand and walk again in a numerous different areas. The device is customizable. So it's designed with a small, medium, and large components. So part of our screening process with Indego is we take very specific measurements to decide exactly what the best configuration of the device for you specifically is. As you can see in both of these photos, it can be used with different assisted devices as well. So a front-wheeled walker is one option, and forearm crutches is another option. Again, really just depending on what works for you specifically, and might come into play that you might use one assisted device, let's say in the home environment, but a different assisted device out in the community. The AFO foot plates for Indego actually go in your shoe under your insole. And so that allows Indego to go outside with you, uneven terrain, up and down ramps. You can walk on grass, gravel, different surfaces, again, because it's really designed with that foot plate in your shoe to go where you want to go. In terms of kind of how Indego is controlled. So Indego is all controlled via an iOS application. And so the actual device itself comes with an iPod, and the application is just downloaded from the App Store. If you're an iPhone user, you have iPhones, iPads, iPods, it can be downloaded on any of those iOS devices, and it connects to Indego via Bluetooth. So if you're in an area, let's say you're outside, you don't have Wi-Fi, no issue. Indego will completely function. All your settings will be saved because, again, it's just a Bluetooth wireless connection to the device. A couple unique features that Indego has, and I have a great video in just a couple slides. Variable assist is one feature for individuals who have muscle preservation, let's say an incomplete injury. The specific assistance from the device can be dialed down to meet what you need. So if you don't need 100% assistance from the device, we want you to use the preservation that you have. And so that assistance can be dialed down from 100% to 80 to 60, again, whatever is appropriate for you. Advanced gait is another great feature we have, and this really allows you to walk at community ambulation speeds. So if you want to go out in the community, walk with family, friends, colleagues, whomever it might be, Indego's advanced gait really gives you the gait speed that those individuals are going to be migrating as well. To get a little more into the modularity of it. So this photo shows Indego broken down into 5 separate pieces. And then those 5 pieces can again fit into a duffel bag. So this gentleman is able to fit his Indego into the duffel bag and again, bring it with him where he wants to go. It can also be worn in most personal wheelchairs. So you can put it on in most wheelchairs, take it off in most wheelchairs. And if you want to propel yourself somewhere before you're ready to stand and or walk, Indego again is designed to help you do that. And then again, it can be used to transfer in and out of the passenger side of most vehicles. And because of the modularity, the lightweight of it, it's really, again, designed to go with you where you want to take Indego and kind of just be part of your everyday activities. So here's just some great photos that actually show the device in sequence for a user who's putting it on in his wheelchair. So there's no specific sequence that it has to be put on and taken off, which is great. So it gives you the option to find out what works best for you. He works kind of from his feet up to his hip and is able to completely put the device on in his chair and do this independently as well. Another option for putting it on and taking it off, this young lady will show us in this video, but she already has Indego put together on her couch. She transfers from her wheelchair into Indego, and then she just has to slide her feet in the shoes, tie her shoes, and then she's up and ready to go from there. So again, lots of options because of the modularity and the light weight of the device. No specific one way is going to work for everybody. And so we work with you, we work with your team to just figure out what that best way for you is going to be. So let's talk about who an ideal Indego personal user is. So an FDA requirement are individuals who have a spinal cord injury at a T3 level or lower, and that can be a complete or incomplete injury. Height is 5'1" to 6'3", and this is a rough range. It's really more determined based off of your specific femur length. So if you, let's say, are 5 foot or you're 6'4", I wouldn't discount you just based on that. I would want to do a specific measurement of your upper leg to decide if Indego would fit your height. For weight, it's weight less than 250 pounds. You have to have enough upper body strength to manage an assisted device. Again, as I mentioned before, there's a wide range of devices that can be used. So that's something else that we just explore those options and find out what is best for you. Healthy bone density is at the discretion of your physician. Intact skin where the device is in contact. So again, we don't expect Indego to cause any skin breakdown. And so we just also want to make sure your skin is intact before getting you into the device. If you have spasticity or spasms, that's not a limitation with Indego. Indego is built and designed to manage spasticity and spasm very well. And then for range of motion, we're just looking at hips, knees, and ankles, and if you're able to get in an upright standing posture to be standing and walking. There's also wiggle rooms within range of motion. So if you have some tightness at your hips, tightness at your knees, Indego can usually accommodate these very well. It's just something that we look more specifically at when we meet you in person. A couple things and photos just showing personal users and what they do with their device. So this gentleman used it at the wheelchair games a couple years ago, performed a number of activities there. Different hobbies, exercise, again, work-related activities, different home environment activities. So this woman wants to stand and wash her dishes, put things in the fridge. All of these things Indego can support. And again, whatever it is you want to do, we want to help you get there. We've also had a number of individuals use it for weddings, graduations, different big life events. Again, just wanting to be standing and in that upright posture. Some clinical benefits that research has shown, but also other personal users have told us that they've experienced personally include improvements in their bowel and bladder programs, decreased spasticity, improvement in trunk control, decrease in pain, improvement in range of motion, as well as improved bone density. And these are all specific to everybody individually. But again, Indego is designed to get you in that upright weight-bearing posture. So a number of these benefits could be seen. Now I want to show you kind of this great video of a gentleman walking in Advanced Gait. So if you remember, Advanced Gait is one of the software suites that allows users to walk at a faster speed that really equals community ambulation speeds. So you'll see him do a number of turns here, and you'll also see him slow down and speed up. And that's where he's able to control going from what we considered standard gait to advanced gait. So right there, he slowed down a little bit, and then he'll speed up here in just a couple more steps. So he's in complete control of the device. He is able to tell the device when he wants to slow down, speed up, and then at the end of the video, you'll see that he's also in control of when the device actually starts and stops. This gentleman is a gentleman who's been using Indego for a number of years, and he is a T3 complete injury. So he has no motor preservation in his lower extremities. Okay, so next I want to just talk a little bit about the process. If you or somebody you know are interested in learning more about Indego for personal use and starting the process. So the first thing would be to contact us at Parker, and we would initially perform a phone screen. That phone screen is just to make sure you meet those basic criteria per the FDA to get into the device. From there, we only need a medical clearance form that's signed by your physician. Again, just saying that, yes, they check off that you're safe to use the device. And then we look at setting up and getting you to participate in a clinic day. And we do clinic days all over. So specific to where you are in Ohio, if you already go to a clinic for therapy, wellness, or you have in the past and there's a team that you like and you want to work with, you can always reach out to us and we can get a clinic day specifically set up at that site. If you don't have a site right now that you're associated with, no problem. Let us know that you're interested and we can get you on the schedule at a site that we're already in contact with. That clinic day gives you the opportunity to trial the device. As long as it meets your expectations, then Indego goes through the process for getting approved for home use. And then you go through a training program. You and then a support person is somebody that you identify to be there to help you when you're in Indego. You're brought through this training program to really be just checked off on skills with the device and making sure you know the ins and outs of the device. Last main thing I want to talk about, which I'm sure a number of you are wondering, is who pays for this device. So there's a number of different options. The two main ones that I want to focus on, the first one is the VA. If you're a veteran or the individual you know who might be interested is a veteran, the VA has a great process in place to provide Indigos to individuals who meet requirements. So if you're a veteran or know someone, please reach out to us because we can help get you in contact with the right people at the VA. The next one is workman's comp. Individuals who have workers' comp benefits have great success with submitting to workman's comp and getting full coverage for the device. We help kind of with the paperwork and what that looks like, but again, a great option for those of you who might have workers' benefits. The other ones for insurance reimbursement, fundraising, and grants. These are on a more specific basis. Insurance reimbursement, reach out to us. We'd be happy to discuss what this looks like for you more specifically. And then fundraising and grants is always an option as well. And we work with a number of organizations who can help you with this process. So really just to summarize, I want to answer any of your questions, meet and talk with you guys specifically about your interest. If you or somebody you know has a spinal cord injury at a T3 level or below, reach out to me. The next slide will be my contact info. Megan has my contact info as well and can provide that to you. But if you're interested in just learning more about the device, if it's something you would qualify for, if it would help meet your expectations, whatever those might be, I'm here, my team is here to help answer those questions for you. So here's my email address and my phone number. Again, any questions, if we have time with, after this presentation or after the next one, I'm happy to answer them this evening. Otherwise, feel free to reach out to me and we can discuss any more specific questions that you guys have. And if you're interested, then find a clinic day or a trial that's close to you guys.
Yeah, if there are any questions, we can do a couple of minutes now. And then if there's any more at the end, we can do that as well. So any questions, couple of minutes.
Does anybody have any questions right now?
Jen, this is Mark. Could you talk a little bit about the safety features? I mean, are there safety features built into the software or the appliance itself?
Yeah, so there is our main safety feature within Indego is called fall mitigation. So one of our big things is safety is always number one. That's why it's an FDA requirement that individuals have a support person. So that support person is there with the individual, even if they don't need physical assistance with the device. They're there for that safety aspect. If something was to happen, that support person learns the device just as much as the user does to help them manage that situation. The other safety feature we have for fall mitigation is to help the user if you were to go too far forward with your balance or too far backwards with your balance. Indego registers that degree of forward or backwards, and it helps bring the user down in a safer position. So you will never fall in Indego like a tree stump to where you kind of just tip over. Indego will help lower you in a position that's safer to where it's always going to protect your head to where you wouldn't hit your head if you were to fall.
Hands and knees.
Thank you. Thank you.
Yeah.
How do you control it?
So it's all controlled off of your posture. So Indego reads your posture and is initiating steps by you leaning slightly forward at your hips. There's settings put in place, which is part of what we, one, figure out in your initial screening, but two, can change over your training. But there's a specific threshold that you slightly lean your weight forward. The device will read that, and that will be what initiates steps. As long as you keep your weight forward, Indego will follow a predetermined step pattern. Once you're ready to stop, you just stand in more of an upright posture. You have to wait a couple seconds. Indego will register that you're upright, you're not leaning forward, and then that will be what tells Indego that you're ready to stop. So as the user, you truly have complete control over when you start taking steps and when you stop taking steps, just based off where your posture is. Good question.
And I have a question. Jen, isn't the time very limited that you can use it? You can't use Indego, go to the mall and walk around, or go to a wedding and walk around as you please, of course.
Yeah, so there are some limitations in terms of battery life, in terms of how long consistently you can actually walk with it. If you're consistently walking, so let's say you do want to go to the mall, you will have about 2.5 to 3 hours of consistent walking. That's without taking any breaks in between. If you are doing more inconsistent walking, so let's say you're going to the mall, but you're walking, you sit down for a little bit, you continue walking, and you're kind of doing off and on walking, then you'll get about 8 hours of battery life with the device. It's not designed at this point, no personal exoskeleton is, to completely replace a wheelchair as a primary means of mobility, but it's definitely designed for those activities that are even consistent walking. You should be seeing about that 2.5 to 3 hours that you could walk without stopping.
Okay, thank you.
Yeah.
How can you go upstairs or sit down?
Yes, so great question. So right now, FDA has not approved personal exoskeletons for stair climbing. You can do like curb cutouts and curbs. There's a way that we can train you to just step up that more of a lip versus actually ascending and descending stairs. But then in terms of a sit to stand, there's a sequence that you do. Again, it reads where your legs are positioned. You're going to lean forward kind of with your chest and your shoulders. And then you do a slight push up through your arms. And that actually tells Indego that you're ready to stand. And at that point, Indego will actually stand for you. So again, if you have no ability to stand on your own, no issue, Indego will be able to help you stand. Great question.
Okay, with out of respect for the time of our
Definitely.
second presenter, we're gonna move on, but Jen, if you're able to be here at the end and there's time, we would certainly love to take more questions if there are any.
Definitely, yes. Hang around.
Yes, so thank you so much for being here and presenting. That was awesome. It's an awesome device. So yeah, I hope people can connect with you and take advantage of that. Okay, so our next presenters are researchers from the Cleveland Clinic. We have Kyle O'Laughlin and Taryn Aurora. I hope I didn't butcher your last name. Sorry if I did. But they are here to talk with us about their research study that's titled Improving Upper Extremity Function in Individuals with Incomplete Tetraplegia using Transcranial Direct Current Stimulation. And I'm going to let them tell us what all that means. So thank you for being here.
Thank you for having us. Megan, can you
Yes.
share my screen?
Yes. Sorry about that. There you go.
That's okay. So good evening, everybody. My name's Kyle. I come from the Cleveland Clinic. We are currently running a multi-site clinical trial in upper limb rehabilitation for cervical spinal cord injury patients. We collaborate closely with people at Metro Health, such as Dr. Nemunitis, who's now here at the clinic, Ann Bryden and Kim Anderson. They've all provided much input along with Dr. Kilgore for the study. And what we're doing is we're combining a non-invasive form of brain stimulation called transcranial direct current stimulation with upper limb rehabilitation for patients that have limitations using their arms. So if you think about trying to reach forward or perform any hand tasks, we're looking for individuals that have those limitations. So if I can go through this here, these are, oh, sorry. I just exited out of that.
Your screen's not being shared.
Let me try that again here. Is that better? I was working on a different.
Yep.
Perfect. So we're looking for spinal cord injury survivors. This had to occur at least a year ago. If your diagnosis occurred more recently, we can just wait until you reach that point of at least 1 year plus. So we're looking for more chronic survivors of cervical spinal cord injury. Looking for both males and females, ages between 18 and 70 years old. And any ASIA level score, ASIA A, B, C, or D, with the caveat that if you are diagnosed as ASIA A, we just look for some motor preservation with a specific test that Dr. Kilgore helped us implement. Another caveat with the study is since we're studying the spinal cord injury and we're in phase 1, phase 2 of this clinical trial, the safety and efficacy of the device that we're using along with in cervical spinal cord injury patients, we can't have any neurological or cognitive impairments. This will help us to understand how our device plus upper limb rehab is helping specifically patients with spinal cord injuries to the cervical spine. No history of epilepsy or implants in the head, and then no cardiac pacemakers. Implants such as baclofen pumps are admissible currently, so we're allowed to include patients with baclofen pumps. And we've actually had patients participate in the past with baclofen pumps. So what's involved? So the study has 22 visits overall. There's a neurological examination. So after going through a phone screen with myself or one of my colleagues, we then bring you to the next phase where we bring you in person and do a physical therapy screen along with a physician screen to make sure you meet the number of criteria that we have for the study. And then there's also pre-tests and post-tests for the study. With these pre-tests and post-tests, we're studying the functional ability of patients to perform different tasks using their arms and hands. And the other day that we have patients come in for, they're actually getting a neurological or neurophysiology study done. So we use this non-invasive brain stimulation technique called transcranial magnetic stimulation, using a magnetic stimulator to study the pathway from the brain to the opposite limb, the more affected limb, to understand how well the brain's still communicating with that limb since the injury has occurred. And as you can see in the image behind me here, this is just kind of one of our, it's a neuronavigation device. It allows us to pinpoint a certain area in the brain to find out which area is best talking with the biceps and the triceps. And during the study, financial compensation is provided. We have the ability for transportation to be provided as well. And for patients that might be coming from a distance, we also have lodging capabilities for the duration of the study. So in total, most patients from the start till the end are involved with us for about 3 months, or about 4 months, including the 3-month follow-up. And I'm going to let my colleague, Dr. Trun Aurora, discuss the time involved in the study in a little bit more on the specifics.
Thanks, Kyle. Thanks everyone for the opportunity to talk with you all today. As Kyle mentioned, this is a clinical trial where we're looking at the effects of direct brain stimulation in improving upper extremity function. And this is a phase 1/2 trial. So basically we are looking at two things. One is the efficacy, how effective the brain stimulation is, but we're also looking at the safety aspects of it. And we are quite an experienced team. Previously, we have done a pilot study in our lab at the Cleveland Clinic, and the results were found to be positive. That is why the Department of Defense have funded us for a bigger study now to have a stronger evidence. So now we are reaching out to multiple sites. We are also testing at Cleveland VA and Kessler Foundation in New Jersey. And that's why we are here today as well, so that we can get a large number of participants. We are looking for about 44 participants to help us with the study. As Kyle mentioned, we are quite an experienced team. Dr. Ela Plow is leading the trial. She is a PT PhD, so she was trained as a physical therapist and she's a researcher. But also we have collaborated with Metro Health, like Dr. Kevin Kilgore and Bryden. And I heard someone saying before that it's unfortunate that Dr. Naminatas had to leave Metro Health, but we are fortunate enough that he's at Cleveland Clinic because he's involved in the study as well. So we are a great team. And in terms of the timeline involved in the study. So basically, if you find someone who is interested in the study, first of all, we go over a screening call, basically where we ask a few preliminary questions over the phone to make sure that that individual will be meeting the eligibility criteria. And once they meet that preliminary eligibility criteria, then we bring them on site where they're examined by a physical therapist and a SCI physician to make sure they meet the overall eligibility criteria, including the muscle strength criteria and any contraindications to brain stimulation. So once we ensure that the participant is eligible to participate in the study, then we go over 2 pre-tests which are separated by 3 weeks. Now, these 2 pre-tests are important to ensure that the functional levels over these 3 weeks are not changing spontaneously, and we have reached a stable function levels. And these involve functional evaluation, which basically entails your motor testing, your sensory testing, and then different performance abilities, including prehension or different kind of grasp. In addition to that, as Kyle showed you, we do a neurophysiological testing where we stimulate different regions of your brain and record the activities from your upper extremity muscles. And the idea is to understand how these pathways which underlie your functional movements are working. So after these two pre-tests comes the intervention phase, which basically involve 15 sessions of upper extremity rehabilitation, which is combined by either a real brain stimulation, which we call real TDCS, or sham stimulation. Now participants can be allocated to either of the two groups, and it's completely blinded. No one knows which group they'll be allocated to, except the biostatistician, which basically performs its allocation. And this is important because we don't want to bias the results by knowing who's receiving the real treatment versus the sham treatment. But irrespective, both groups receive rehabilitation. And this rehabilitation is performed by a licensed physical therapist or occupational therapist. And this is specific to the functional levels of each individual. And at the end of these 15 sessions, we perform another test to see what are the changes in the functional levels and neurophysiology of these participants. And at the end of it, we send the participants home for some home exercises for 3 months, and then we bring them back again to the clinic and we perform another functional testing. So now each of these tests, which we perform before and after the intervention, are divided into 2 days. So first day is the functional testing, which lasts for about 4 hours. And then the second day is neurophysiological testing, which again lasts for 4 hours. And the intervention, where you receive treatment, lasts for about 2 hours, where there's a break in between 2 hours to avoid fatigue. And for first 30 minutes of each hour, you'll receive brain stimulation. So that's the overall picture of the timeline involved in the study. And in total, there are 23 visits. So Kyle said 22 plus 1 for screening, for the screening by therapist and physician as well. So that makes to total 23 visits. And you'll be with us for about 4 to 5 months, including that 3-month for follow-up evaluation. So I'll let Kyle talk about if someone is interested in the study, how they can contact us.
So I prepared our contact information within the Cleveland area. We do have the Cleveland VA and the Cleveland Clinic, so we have a single phone line to call. That is this, oh, it's not, let me click. Let me just come to here because I want to highlight it for you. So the best number to reach us by currently is this 216-445-7841. If anybody's immediately interested, if you call that number and leave me a message, I can reach right back out to you. We also have our email contacts here as well. Just so everybody knows, this is a 4-year grant. We are currently in the 3rd year of the grant. Due to recent COVID-19 suspensions, we anticipate that we can have an additional year after the study. So we may have an additional 3 years left to perform this study. And we are about halfway through our personal recruitment number at the Cleveland Clinic. So there still are more spots to participate. So if anybody has any questions or would like to find out more information, whether they might be eligible, what days, how many days they have to come in, that you can always reach out to me. And while I have you guys here, most of the times what the beauty is about having these Zoom calls is I can show you the device. Most times we don't take it out of the lab space, but I stayed here today. So I don't know if any of you are familiar with TENS units that are used, that are battery operated. Our device is very similar. It's a battery operated device delivering a direct current with 2 sponge electrodes. So the active sponge electrode is put over the brain area that is determined to be the hot spot for the muscle that is weaker in the weaker limb. So if your triceps is weaker on your left arm, we would put this over the area in the brain that is the controls the tricep that has been determined during our neurophysiology testing. So we're trying to pinpoint that area while also delivering a widespread current. So one pad goes here, and then the other pad would go here, and the current would spread from the pad here to the pad in front. Do we have any questions?
Yeah, could you go back to slide 2?
Yes. Sorry.
Just, yeah, so that 1, 2, 3, 4, that's 6 bullet point, no other neurological or cognitive impairment. Would a stroke be in that category?
Yeah, so examples of this would be symptoms or diagnosis such as stroke, anything like Parkinson's. If you've had a traumatic brain injury that's been diagnosed, that's another complication at this current time. The reason for this limitation is because we want to understand the spinal cord injury, the effectiveness of our device plus rehab on patients with the spinal cord injury specifically. And to study that more, to get more robust results, and to understand the effectiveness on spinal cord injury, if we involve somebody with a stroke or the Parkinson's at this time specifically, we might not be able to answer the question specific to spinal cord injury. We might not know why some patients didn't respond and why others did if they have other confounds.
All right, thanks.
Mm-hmm.
These individuals got to come down to Cleveland Clinic 23 times. Are they going to be reimbursed for their parking, their food, their caregiver needs?
Yeah, so all the parking is reimbursed. We do have the ability for transportation coverage. We can cover the kind of financial aspect of transportation. There is a stipend at the end of the study as well. With the study currently, unfortunately, we don't have the necessary financial coverage for the actual caregiver costs. But anything else related to the study is can be covered by the study finances.
Thank you.
Do you have to shave the head where you apply the pads on the head?
No. With the transcranial direct current stimulation, the pads get soaked in saline, and the beauty of the device is it gives us the contact quality that's there. So a shaved head is not necessary. We've had patients who've had we've had discussions with about their braids that they put in their hair because they would get their hair braided and come in for the next visit, and their braid might be right in the area where we were trying to stimulate. So that's one thing that we end up reminding patients. Make sure if you get braids or something like that, just know that if it's in the area that we're trying to stimulate, the contact quality might not be as good, and it might be a little bit more irritating. But the shaved head is not necessary to participate in the study now.
Okay, thank you.
And if you see in the image on this screen here to the right, this individual, an old student of ours, has the device on, and they have hair. So most of our patients do have hair that are in the study, although it doesn't matter if you have hair either way or not for the stimulation to be effective.
And there's a question in the chat asking to explain how the TDCS feels and its safety.
Yeah, so great question. The safety of TDCS. So that is one of the things we're studying in this study with cervical spinal cord injury patients. Now, the safety of TDCS is known to be minimal risk across all populations. So it's the risks involved with TDCS are not very high. Some are itching, burning, tingling, irritations on the scalp. Some patients report headache after having it. This confusion and disorientation are on the more rare side, but those can occur. So that's one of the points of the phase 1, phase 2 clinical trial, is to understand the safety of using this device with subjects. I can personally report that our subjects currently most commonly report the itching or tingling underneath the pads where they're being stimulated. So that's the most common. Sometimes we get a burning sensation reported, and that's only because there's not enough saline usually on on the underneath the pad, and the skin directly underneath the pad might become sometimes irritated.
And all these things are temporary. So they are just transient, last for some time, and then gets better on its own.
And did you say you've been doing this for 3 years, this study already for 3 years?
We're going into the third year. So we've completed 2 years with this phase 1, phase 2 clinical trial. Before the start of this study, we did have a pilot trial where 18 subjects went through with us here at the clinic. And that study lasted, I believe, 3 years as well.
Can you share with us what you guys found out so far?
So we can share that with the phase 1, phase 2 clinical trial, or with the pilot study leading up to this phase 1, phase 2 clinical trial.
Yeah, just tell us what you guys know.
Active stimulation group was trending to be more effective. So active stimulation plus sham was trending to be more effective than the sham stimulation plus rehab. So active plus rehab plus and sham plus rehab for 10 visits was more effective. Okay, so it was trending towards that positivity. We did have some sham patients who did extremely well as on top of that, so that might have skewed our results a little bit. But yeah, we were trending in that direction. So the sham group seems to be showing those results.
And these improvements were in the upper extremity motor score. So basically the muscle strength in the upper extremity, in the upper extremities. And so there are papers out that have already been published. We'll be happy to share these papers with you guys at the end. And it contains all the details about the pilot study.
Thank you.
Mm-hmm.
Can you show a picture of somebody getting stimulated so people can have an understanding what it would look like?
Are you talking about the non-invasive brain stimulation?
Yeah.
I have this image here that we readily use.
But an active video, just to see that they don't be jumping all over the place like that.
Yeah, that's true.
We would have loved to share, but
I don't know if I have any videos where the face is currently blacked out.
yeah.
How about one of your students?
No, not currently. The students didn't have any videos. We've been trying to get more and more videos prepared going forward for hopefully a phase, the next phase, phase 2B potentially, where we get more patients involved.
You could do a live demo. You're right there with it.
I could show you right now easily how well.
I'm just kidding.
But yeah, it's very light. I've had it done multiple times as we try to test new things out, just so I can feel for myself how it feels, to let patients know. I don't know if anybody's used a TENS unit or had some type of e-stim done. It feels just like that, but now on the head.
Hey, Kyle.
Yeah.
Am I allowed to speak to any of that?
Yes, you can attest to that.
All right. I did go through the study myself. I can say that the tingling was very, very light. I didn't have the itchy sensation or any of those effects, that some people had. I did have a full head of hair when we first started it, so just kidding. I'm only kidding. I still want to. But honestly, it was a very, very beneficial study. I can attest to that.
Thank you, John.
I'm a C2 to T5 injury. I have a device on that area. With that, I'm losing use of my right arm. I don't know if that's part of the injury or if that's something else that's going on.
So you say you have a device. Where is your device located?
T5 to C2. It's up. I can't think of the word.
Is it a pain stimulator?
No, it's a to hold everything together.
Oh, that's where your fusion is.
Yes, that's the fusion, T5 to C2.
That would not be an issue. So we've had patients had fusions or rods all the way up to right around that area as well. That's not the metal that's implanted into the cervical spine is not an issue at all. The metal that, if there's any metal, let's say you had a bad accident and there's metal in the skull, currently we're not approved to do TDCS over that area, just because we wouldn't know the effects of how the TDCS disbursement would be with the metal that might be planted in the skull. But anything below the skull area would be fine.
What would
Is there a way to tell if that is from the injury or another reason? I did separate my AC joint. I don't know if that's part of the problem now or if it's from the spinal injury.
So
Did you say you were losing function recently?
Losing strength in my right arm.
Well, that
I can't even.
me, and you would probably want to see your doctor to talk about that, just to make sure it's not something else.
Yeah, the problem is now I have SUMA insurance, so I'm not eligible to go to Cleveland Clinic. So I have to be able to find someone down here
Well, no,
that's
you don't have
willing.
to come here. I'm just saying, go to one of your. Where are you at?
The Akron area.
Well, have you seen your neurosurgeon?
That was done at Cleveland Clinic.
And you can't get up here to see anybody.
Well, it wouldn't be covered by insurance. I'd have to pay cash.
That's a problem, but it sounds like you've got a problem and you can't let it go too long.
I'm doing hand weights, but one day it'll be okay. The next day it's pain trying to do things again. And I can't even start my weed eater anymore.
Yeah,
So maybe I need to go to a doctor down here and see.
Well, I would go
if
to
I can get
somebody
any
down there at least to get an idea what might be going on.
Orthopedic or neurosurgeon?
Either orthopedic neurosurgeon or PM&R, somebody has some spinal cord experience.
Because they just
or even neurology.
Changed Crystal Clinic. I was going there years ago when I separated the AC joint, but they don't cover them or not as much anymore. They want you to go strictly to SUMA doctors.
Well, see if you can get hooked up with a either your neurosurgeon or a neurologist or a physical medicine doctor. That's
okay.
Because you don't want to let something slide by if something is happening either in your spinal cord or your peripheral nerves.
Yeah, because I'm probably have lost some of my balance in walking also. So it'd be good to go to somebody and at least see what he says.
Yep.
Yeah, and in regards to the study, we would always, we're in research, so we can't guarantee anything. We can't guarantee any benefit from participating with us, and we would refer you to your clinician first before even come see us, even over the phone. That's what we would do.
Okay, I mean, if nothing else, I can always come up and see, I think it was Dr. Steinmetz, and just pay cash.
He's a good doctor. You look pretty young. You got a long life to live.
I give him credit for me walking. Because I couldn't even stand when I went to him.
Gotcha.
Okay. Any other questions for either presenters? Okay, if there are no other questions, then we will go ahead and end the meeting. Thank you all for coming tonight. I hope you found something interesting, beneficial, spark your interest. Our next meeting in February, we will have the Adapted Sports Program of Ohio, talking about all of their different programs, how you can get involved, and where they are located. So stay tuned for that. A replay of this meeting will be out by the end of the week, we will say. And then with that recording will be all of the Google Forms that I mentioned at the beginning of the meeting. And yeah, if you need anything from us, get a hold of us. We're on Facebook at USANEO, email us, our website, all of that good jazz. So I hope everybody has a great rest of your evening and a great month, and we will hopefully see you next month.